Good morning, everyone. I'd really like to warmly welcome you on behalf of Gina and myself to this session on its new and improved innovations in RT and PT. I hope that you'll really enjoy this session. I think it's full of very informative things, and anybody that's not here is seriously missing out. So well done, you've won the prize already. Can you not hear me? Sorry. Just for information, the questions we can take on the app, but also you can come up to the mic and speak if that's okay. So it's my privilege to start this session off. I'm just going to give you a little bit of introduction, then we'll introduce the first speaker. So we have nothing to declare on this. And the session objectives today are looking at recent innovations in PT-RT that are enhancing care for people with CF, the evaluation of the clinical impact and feasibility of integrating modern technologies into routine practice to manage our people with CF better, and apply evidence-based strategies to optimise airway clearance, exercise, and the multidisciplinary consultation. We've seen through this conference about ageing population with cystic fibrosis. We also know that innovation and modern technology has had a part to play in that. We've had to flex as physiotherapists and RTs to manage the way that we care for these patients because they are demanding a different way of being cared for. The last 5 years have seen a massive change in. This is a terrible feedback, I'm so sorry. Okay, so the last 5 years have given us CFTR modulators, and that's had a massive impact, but we've also seen the impact of the pandemic on how we look after people with CF, using virtual consultation and virtual surveillance and all these modern technologies that we can use to influence their care and make our jobs easier in some respect and harder in other respects. So we have to really flex to meet their needs. So what the progress has enabled us to do is to give us a significant potential to enhance the management of people with CF and give them convenient, personalised and engaging solutions. So if we can offer these, then we'll have our patients being cared for better for longer. The tools that we have available to us now enable us to improve adherence to therapy, extend the reach of screening in some issues, facilitate remote monitoring, and that's particularly useful for people who live in a geographically remote, distant area, and support overall well-being, empower people with CF to manage their health a little bit better, and contribute to better health outcomes for people with CF. So what can you expect from this session? Well, we're going to explore and demonstrate the synergy between new and improved approaches to clinical care, from digital health platforms and chipped airway clearance devices to novel exercise programs and integrative care in the holistic management of people with CF. So it's my pleasure to introduce the first, I unashamedly have hijacked this session because I'm also a PhD researcher looking at the impact of digital health on people with cystic fibrosis and physiotherapists working with people in cystic fibrosis. So this session is really about what my research is about, so that's why I hijacked it. And I'm really interested in what your say is about this. So if you're happy to fill in this, it's a QR code. I'll also put it up at the end. It'll take about 20 minutes to complete, so you don't have to do it now, and you can come back and complete it at a later date. But I'm really looking forward to hearing some of your experiences and opinions on digital health tech and how we approach the management of CF. And I think this session will really deliver some of those. So it is my pleasure, she says, to introduce Professor Eleanor Main. Eleanor is a Professor of Physiotherapy at the University College London, Great Ormond Street Institute of Child Health in London, UK. She's the University College London's first Professor of Physiotherapy and has over 30 years' experience in clinical paediatric physio, postgraduate education and translational research. Eleanor has led Project Physio, which she will speak to us about now and explain all about chipped devices. Thank you very much, Eleanor.
Thank you so much, Lisa. Can you hear me okay at the back? And Gina, thank you for inviting me to beautiful, slightly rainy Seattle, and for asking me to contribute to this session, which is very much an area close to my heart as well. Lisa, I have no relevant disclosures for this talk. So I'm going to be sharing with you some findings from Project Physio. And Project Physio, I guess this is a study that used remote monitoring to explore kind of real world effectiveness of airway clearance techniques. And one of the key questions that we'll ask today is this question of whether quantity or quality are more important in clinical outcomes for people with cystic fibrosis. And the question's quite critical, actually, not only for helping us guide future clinical guidelines, but also for trying to tackle this matter of reducing burden for people living with cystic fibrosis. And Project Physio kind of started almost a decade ago now, and it was in an environment where highly effective modulator therapies were not widely available to everybody, and there was this kind of tension in the air. And the tension in the air was about airway clearance being, literally the most burdensome of all the therapies that people with CF have to do. At the same time, both people with CF and healthcare professionals were saying that it was also one of the top 5 most important things. So there was this kind of, what do we do with this reducing the burden, but with this very important treatment? And at around that time, all of this, the whole raft of Cochrane systematic reviews hadn't really come up with any a clear signal that one airway clearance technique was better than another. And so the word on the block, the kind of informal view of everybody out there was that it didn't really matter what airway clearance technique you used, as long as you did one of them. So something was better than nothing. And as it turns out, and you'll see today, that's not entirely true, actually. Because if you perform something poorly, you'll see that it is really just as bad as doing nothing at all. So I look forward to trying to persuade you that quality is, in fact, a very important thing, and that if you're going to do something, you have to do it well or not bother. And so, in that time, and indeed now, airway clearance techniques are prescribed fairly early on. And we pride ourselves as clinicians that we settle families down and we explain in graphic detail exactly how people should perform these techniques. And then we send them out into the big wide world, and we assume that they perform those techniques exactly as we have recommended. But deep in our hearts, we're never quite sure that that is what happens when you send them out on their own. And so Project Physio emerged from this uncertainty. We wanted to kind of peek under the bonnet to sort of look in that black box of adherence. What exactly were people doing at home in terms of airway clearance quality and quantity? And so we collaborated with a wonderful genius engineer and designer who used to live in London but now lives in Seattle, and he helped us build this tiny little sensor that you could clip on via a wide cuff to most commercially available positive pressure devices. And once that little sensor was in place and people were at home, every time they took a breath through this device, every breath that they took would be measured and transmitted automatically to us. And so the kind of data that was coming in, and this is a full airway clearance treatment for a positive pressure device, and you can see that the data up there shows the kind of the clear sets, perhaps 10 sets of 10 breaths with nice pauses there for huffing and coughing. And you could extract from this data. We had a quite sophisticated data pipeline that looked at all of these things, and you could say, well, how long is this treatment? How long are the sets? How many sets are there? How long are the breaths? And how much pressure are they? And we could get down into granular detail, breath by breath, and say, well, what was the peak pressure of this breath? What was the mid-expiratory pressure? What was the breath length? And those things are quite important for these positive pressure devices because we give quite specific advice. You want a stable mid-expiratory pressure between 10 and 20 centimeters of water, and you should, have an active breath from tidal volume, but not forced or prolonged. And so those are the kinds of pieces of advice that we give to people, and we wanted to know to what extent they were achieving those. And so we collected sort of fairly granular data from 145 children and young people with cystic fibrosis, which is quite a big group, and over a 16-month period. And all 6 to 16 years of age from 3 big London CF centres. And everyone was given a tablet to take home and a Fitbit and one of these airway clearance sensors. And all of that data came into this secure digital research environment and was integrated at that point with clinical data from each of these people, including genotype, lung function, microbiology, hospital admissions, and so on. And so I'm not going to dive beyond that into any detail, but the protocol for this is published in BMJ Open, so feel free to scrutinize it at your leisure. But in the end, over this period of time, we managed to capture 55,500 individual airway clearance treatments, and that represented around just short of 5 million individual breaths. And our findings were pretty extraordinary, because once you have that level of detail, you find despite this fairly consistent advice given in clinic, what actually happens out in the field is absolute mayhem. And you'll see some examples of this. So, we talk about the 10 to 20 centimeters of water, but the top row there, we're between 80 and 100 centimeters of water with these massive wide gaps between sets of breaths. The bottom row is just chaos. There's no sets. The breath pressures are all of different sizes, and no pausing for huffing or coughing. Here, again, quite high pressure between 30 and 40 centimeters on the top row with no sets for huffing and coughing. And then the bottom row, somebody's styling it out there. So at the end of every set, they do this kind of big high pressure breath. Nobody told them to do that. They just did it anyway. Again, high pressure breaths here, 60 to 70 centimeters of water, and then quite a nice looking treatment at the bottom here. But what was a kind of proper take-home message from all of that was that once somebody had established their routine and their pattern of airway clearance at home, they really did stick with it, so it was deeply ingrained habitual behavior. And so you can see these are 3 different participants. Each row belongs to a different person. And you can sort of see, even to the detail, the top row, the person finishes each of their treatments with a tiny little signature of small pressure breaths, and that happens every time. You can see the middle row all belongs to one person, but they're different treatments, and the same with the bottom. And so you start asking these, I think, quite important questions, which is which one of these is better, and do clinical outcomes depend on the quality of your treatment, especially when we're faced with this incredible variety out there. And then to add to the complexity, there's a bewildering kind of set of positive pressure devices out there for people to choose from, and each one of them has a slightly different kind of pressure time trace. And just when you think, well, that's fine, at least we know what these look like, it's not the case at all. Here we've got, on each different line, the top is a cappella, then aerobica, then astropep, paripep at the bottom. And each of the colors on each of those rows is somebody using that device in a completely different way. So again, you can't even depend on, I'm going to send them home with an a cappella so I know what they're going to be doing. This device will help them do it right. And just to orientate you, that kind of pale green line of each of these is the 10 to 20 centimeters of water that is recommended. And you can see here that there's a huge number of breaths that are not quite making the grade. And kind of sticking with that idea for a while, here's the sort of breath pressure and breath length with different devices. Along the top is breath pressure, and you can see a cappella, aerobica, astropep, pep. And you can see that each one of those tiny little grey dots is the average of breath pressure and length for those specific devices, you know, the 55,500 treatments. And you can see that each of these devices tends to, but not exclusively, operate in specific kind of zones. And physiologically, that makes sense. So the acapella, you can see on the top row, tends to be operating in a higher pressure zone. But if you're doing breaths with high pressures, you can't sustain them for very long. So you'll see the acapella then has quite short breath lengths at the bottom. And you can see that the paripep, which is 4 along, has got reasonable breath pressure, but the breaths are much longer. Physiologically, that all makes sense. And then there's another take-home message, which is you, as a clinician, have no chance of knowing what 100% adherence looks like. So all of these people, 5 of them, would come into clinic and tell them, and tell you with absolute honesty, I do 100% of my treatments. But you can see that each of these people does something completely different, and does that matter in terms of clinical outcomes? So at the top, A, clearly defined sets within the right pressure, nice gaps for huffing and coughing. B, long breaths, low pressure, no clear sets. C, high pressure, uneven sets. D, no sets, quite high pressure. E, that whole treatment took 3 minutes. Even though they're quite well-defined sets, but they'd all come in and say, yeah, do you know, I'm 100% adherent, and they'd be right. So how do you begin, and how did we begin to kind of tease out this matter of quantity and quality? And quantity is easy. You go, how many treatments did you do? How many breaths did you do? And we've talked a bit about this kind of guideline of 10 to 20 centimeters of water for positive pressure devices. And expired breath length is a little bit more complicated, because youngsters will have quite a short expired breath, and older kids will have longer ones. But this advice, which is pretty vague out there, which is give an active but not prolonged breath. We'd work at their published data on what an expiratory breath length would look like for children of different ages. And so we simply used that to say, well, we'd want your breath length to be around about the end of what would be normal for someone of your age, and it's allowed to be another 40% past that. And so that became, it's fairly arbitrary, but you have to make a decision. It sort of gets a guideline in there that it's not prolonged, but it is a bit longer than normal. And so this is the quantity. This is very easy. Each one of these bars is a person, and this is the number of breaths that they do per day. And there's a kind of median and interquartile range for everybody. And the big old red line through the middle is around 200 breaths, which is kind of, if you're doing 2 treatments a day, 10 sets of 10, that'd be about what you'd expect. And you can see automatically that there are some people that are kind of way beyond what you require on a daily basis, and some aren't even coming close to the kind of halfway mark on number of breaths per day. And so you might quite reasonably ask this question, are those that are doing more breaths per day a little bit better off than those that are doing fewer? And then if you kind of get all of this stuff together in the quality matter, you get a picture like this, where you've got on the y-axis pressure and on the x-axis breath length. And you sort of want, there's that blue rectangle right in the middle, and the blue rectangle represents in this population a kind of Goldilocks technique, where your breath pressure and your length is all right, and it's in exactly the right place. And you can see that D over here is that kind of a breath with a mid-expiratory pressure in exactly the right zone and the length perfect. But A is one of those tall, high pressure breaths and way too short. B, the pressure's okay, the breath's too short. And C is the breath is really long, but the pressure's okay. And so you've got to wonder, well, does it really matter if you're in the blue box or not? Turns out it really does matter. And so I'm going to orientate you. This is one of the kind of key findings of this study. And on each of these 4 blocks, you've got FEV1 on the y-axis, and you've got on the left-hand side number of airway clearance treatments per week, and this is per month on this side. And we're going to stick with the top two to begin with. You've got three lines. You've got a solid line that you can see quite clearly, and the solid line represents all 55,500 treatments. And if you look at that solid line, it's quite flat per week and per month. And that means the more airway clearance treatments you do per week or per month, it doesn't really make much of a difference to lung function. Yeah, it's a fairly flat line. But the two dotted lines tell a very different story. And the two dotted lines are when we've divided up the solid line into those that are conformant, and that's the upward trending dotted line, and those that are non-conformant with recommendations. So the upward trending line, you're in the blue box. You're doing your treatments as recommended. And you can see there, the more good treatments you do, the better off you are in terms of lung function. But you can also see the more bad treatments you do, or the more treatments that are not as recommended, the poorer your lung function is. So let's leave those top two and come down to the bottom two. These are non-compliant patients. And so that dotted line down there, it represents the more skipped treatments you do during the course of the week, the worse it is for your lung function. And that is per week and per month. And if you look quite closely and you see these two bottom rows and you look at the slopes of the poorly conformant treatments above, actually the slopes are very, very similar. So my point, which I made a bit earlier, this idea that if you do something poorly, it's almost as bad as doing nothing at all. So in this sense, quality really, really does matter. Again, this is a paper that's been published in the ERJ, and so please do go and scrutinize it at length if you'd like to. But the kind of take-home message here was that airway clearance treatments are beneficial, and palpably so, in terms of lung function. And these are linear mixed effects regression models. So we took into account whether you are on modulator therapy, whether your baseline FEV1 was high or low, what your age was, how many admissions you'd had. So all of those things had gone into the model. And despite that, you could still see that if you did your airway clearance treatments, there was a strong and significant association between quality of treatment and outcomes. But only 21% of the treatments overall were in the blue box. And you could see that from that graph that I showed you. Only 21. So nearly 80% of people were spending quite a lot of time and energy doing treatments that had no impact whatsoever. And so what we took, I can't blame these youngsters for not knowing what to do when they got home. Some of these kids are 6 or 7 or 8 years old. They get seen in clinic once every 3 months or so. Not every clinic visit comes with a kind of check of technique. And so I can't really blame them for going home and styling it out on their own, but there is a consequence to that. And what we've taken from that is that we need to have a better way of providing sort of clear feedback on what the correct technique is. And so we've started an innovation study, and just started recruiting this very week, on Monday. And we've already got 8 families who said that they want to come into this pilot study, and I'll tell you more about it. We worked with a wonderful design collaborator, and he's turned our, simple sensor into a sensor and real-time feedback device. So every time somebody breathes through the device, it senses your breath and then tells you for your age how long your breath should be and to stay in the pressure zone that has demonstrated benefit. And again, it's one of those interrupted time series designs as before. So we begin for a month or so just getting the baseline. What is your baseline? Styling it out at home technique. And after that, kind of ramping up different feedback mechanisms to see which is most effective, all the way up to a thing called full coaching mode, which I feel I've tried it. And frankly, I think it's going to be very useful and interesting. And so I can't wait to see what the outcome from that study will be. And if the results are promising, and I think there will be, then we'll try and do a bigger multi-center study. So if you want to collaborate, let me know, and we'll make it happen. There's no reason why it shouldn't be national or global, because it's all kind of in the cloud, Just saying. So thank you so much for listening and for coming to this session today. We've got in our team the genius, 2 physios, 2 data scientists. And quite honestly, I think that's a team made in heaven. Absolutely love it. So very happy to take any questions from you, and thanks for listening.
Does anybody have any questions? If you want to come up to the mic, that'd be wonderful. And to start you off, Blythe, we'll wait for you. You go.
Thank you for a wonderful presentation. I always get this question about with PEP, mouthpiece versus the mask. Did you find any differences with pressures, or you may not have separated the two?
No, and indeed, most of our youngsters in London were just using mouthpiece. So
same with my experience.
Yeah.
But I know a lot of the original research was done with the mask. But I'm glad to see that there's a lot more with the mouthpiece too now.
Yeah. And it's interesting because you can, like, kind of, I'm reluctant to say this, but I'm going to anyway. With PEP and pari-PEP masks, you were more likely. So there, 24% of the treatments were, in fact, compliant. And when you brought it down to the oscillating PEP devices, there were far fewer, about 9 or 10%. And so that kind of implies this idea that, well, maybe you should be telling everybody to do PEP. And I think that's not true, because for each of these devices, you could get a good technique out of them, but lots of kids were not managing to do so. And the inherent kind of resistance qualities of these different devices meant that, depending on your own coordination, you got it right more often than not with some devices over others. So.
Thank you. And just to share a tip, sometimes I make it relatable for the little kids that it's like doing your homework. When you've done your homework, but you write 2 + 2 = 5, that may not be the best answer, but technically they've done their homework.
Yeah. 100%. I just love there's so many people making such an effort out there, and it troubles me that we need to help them get it right. These are complex interventions, aren't they? They're not taking a blue pill at 9 a.m. There's a lot more going on.
That was really interesting, Eleanor. My question was, when the people with CF originally were being tracked, did you find that they did better quality sessions, which then sort of tailed off over time because they kind of got used to being tracked? Or is it that they actually believed that this is the way that they were meant to be doing it, and they kind of had a same pattern?
So, there were, I think, some negligible kind of drop-offs from early, but this is a 16-month study, and you kind of would get bored of being tracked fairly early. And also it was a bit dull, actually, because you clipped this thing on and you didn't get really, there was a little light that went on, but you didn't really know, you didn't have feedback, unlike this study that we're about to start, where you will start seeing exactly how things should be done. So there was a little bit of a drop-off, and it was partly families who were generally non-compliant, and they thought like being in the study would suddenly help their child, and maybe it did help for a couple of weeks, and then there was a bit of drop-off. But others are diligent, day in, day out, and are pretty impressive, except for the quality thing.
Yeah. Thank you.
Yeah.
Hi there. Thank you for your talk. I was curious if there was any thought to a similar technology being applied to the Huff technique, because a lot of us in the US are, doing the vest and then advising the Huff, but we know there's a large variability in efficiency of doing that as well.
Yeah, it's such a good question, and it's quite tricky because the Huff is a kind of open mouth, open throat thing, and so we did wonder, those little cardboard cups that you put in, that sometimes you encourage people to use the mist up the mirror. But we didn't explore that further, and so we didn't measure that during each of those gaps, huffing and coughing was happening. You saw quite a few people who weren't. But I definitely think it's worth a go. It's just how do you measure the pressure of that huff at the same time as, not creating resistance, which you don't want to do with a huff. But I still also think about the vest. It's also a complex maneuver. And, bizarrely, this isn't the first time I've come across this idea of the way you do something is more important than how often you do it. After my PhD study a million years ago, somebody called Rachel Gregson had developed a pressure sensing mat. And we measured a whole lot of physios, doing the hands-on vibration stuff. And there we found all kinds of really important stuff, like if you vibrated too soon while somebody was still breathing in, then that had a bad effect. Or if you vibrated too late when the lungs were half empty, then that wouldn't. You had to get it just right. So I think probably, I don't know what's going on with the vest at home, but I bet there are some people kind of with their feet up on the sofa doing all kinds of things. And I wonder if quality is not an important aspect there too.
Thank you.
Sorry, long answer to, I don't know how to measure a huff, but...
We have a question from the app, and this will be our last question so we can move forward. Where does funding for these tech devices come from, and how would you suggest other centers advocate for the technology?
Yeah, well, both of these sensors were made very specifically for this study, and we talk about this too, because I think if it does turn out to be useful, then how do we make it available to others? And in what format? It doesn't have to be as it currently is. It doesn't have to send data. It could be a standalone, you breathe into the device and get the feedback back. But in the end, grant funding was what allowed us to do these studies. And I hope, possibly places like Great Ormond Street might start out small and say, well, this might be useful for our cohort of patients. Or indeed, there's so many of these withdrawal trials at the moment, the idea of them, but the idea of withdrawing something, you saw the flat line when you put all the treatments together. And if you withdraw something that isn't particularly effective, then maybe no big deal. But wouldn't it be better to kind of up the quality of those treatments so that there is a benefit? And I think all those kinds of studies need to start exploring quality as an outcome measure in these trials, so that maybe when you say what is the funding for that, maybe those sorts of trials, if we put this kind of quality measurement into those trials, it'll take off and possibly be a potential device that our patients can use in future. And that's certainly what we hope we'll be able to offer in the end. Good luck.
Thank you, Eleanor. Thank you for that. That was awesome. Our next speaker is Laura Blanche. Laura is a clinical specialist physiotherapist in Newcastle Adult CF Center in the UK. She has been working in CF for 13 years. Laura has a keen interest in digital health, has been involved in the setup and position of the center's telehealth services. She also participates in the European CF Society Healthcare Group. Welcome, Laura.
What's your name? Oh, that's a good start, isn't it? Hi. Thank you for the introduction, Gina. It's a real privilege to have been asked to come and speak here today. So thank you for all attending. I just wanted to share with you some insights into the newer approaches that we're taking as a service to support our patients outside of the traditional hospital setting, and to provide their care beyond the hospital environment. So here's my professional disclosure. Firstly, I thought it was just important to discuss the whys. Why are we looking for alternative ways of delivering care? Why is it not okay to continue how we always have, seeing the patients in the clinic or the ward environment and providing their care there? So a major contributor to the change in direction of care is the obvious driver of the COVID-19 pandemic and all of the restrictions and concerns that came with that. But telehealth as a concept has been around since long before the dreaded pandemic and has only been accelerated by necessity over the years since that first lockdown. So what have been the drivers to deliver care beyond the hospital walls? Firstly, we can see that telehealth services are recommended in the CF clinical guidelines and standards of care. The 2017 NICE guidelines for cystic fibrosis recommend providing remote clinical services and considering telemedicine or home visits for routine monitoring when they are appropriate and if the person with cystic fibrosis prefers it. And further to that, the UK Cystic Fibrosis Trust Standards of Care talk about offering a range of approaches, including telehealth and home-based care, in order to have the flexibility to meet the needs of our patient population. So there are definitely several economical drivers for advancing healthcare beyond the hospital walls. Virtual healthcare can reduce costs by decreasing patient and clinician travel, by reducing the need for physical facilities, and optimising the use of clinical time. So this in turn leads to increased operational efficiency and improved productivity. So as a large regional centre, we serve over 350 patients, with some living over 100 miles from our centre. So we're keen to use virtual healthcare to improve the allocation of our resources and to ensure that patients receive timely care in the most appropriate environment. This can often save the patients a great deal of time, cost and loss of earnings that would be imposed on them if travelling several miles to the hospital base. So while virtual healthcare has its own carbon footprint from digital infrastructure, research shows that overall emissions are substantially decreased by minimising the need for in-person visits. Studies have shown that replacing in-person consultations with virtual ones can significantly decrease greenhouse gas emissions. And it has been suggested that virtual appointments across the National Health Service as a whole in the UK could save 232 million road miles annually. So that's equivalent to 426 kilotons of CO2, or the annual energy use of nearly 58,000 homes. So evaluation of the cost effectiveness of telehealth is difficult because of lack of heterogeneity in services worldwide and the huge variety of terms used to describe such services. So here are some of the many ways in which telehealth services are being provided globally. There's also a huge variety of language use in the literature to describe telehealth, some of which I've included on the slide here. But despite the variety in language, the core principle is the same, with telehealth encompassing any interactive teleconsultations between a medical professional and a patient. So having touched on the background and our rationale for telehealth, I'm just going to share with you a brief timeline of the progression of our telehealth support service over the years within our regional adult CF centre. So our telehealth journey began in June 2017, when we first initiated remote support for our patients who were receiving home IV antibiotics for an exacerbation of their CF. So we completed a small feasibility study over an 8-month period, which included providing telehealth support for 24 patients to receive home IV treatments. As we cover a large geographical area in the north of England, a lot of our patients do have to travel a significant distance to the CF centre. And this is one of the many reasons that patients choose to have IV antibiotics treatments at home, and our team are keen to support them with this. We originally introduced the telehealth service to support patients who were already receiving IV antibiotics at home. So we already had that service going and we wanted to enhance that support. So this included the use of a texting system, home measurements of weight, FEV1 and oxygen saturations, and then telephone consultations. And for this initial telehealth service, we used the Florence digital software that was already established within our trust. So after receiving some positive results from the initial feasibility study, we were then generously donated some home monitoring equipment from a local CF charity, which enabled us to continue this service beyond the original study. But unfortunately, in June 2018, our trust changed the digital platform from Florence to HealthCall, and this caused a great delay in changing our bespoke programme from Florence to HealthCall. So kind of halted the service a little bit. And then came the COVID-19 pandemic, where we found ourselves rapidly increasing our support out of necessity to meet the healthcare needs of our isolating patients. Our accelerated use of telehealth saw us providing exercise and airway clearance support using the NHS Attend Anywhere video calling platform. And by September 2020, this was then an established avenue for routine physiotherapy reviews. So in March in 2023, we set up a virtual ward to enhance the support provided to our patients who were receiving home IV therapies. And we've since progressed our telehealth offering further by providing virtual postnatal reviews since November 2023, and more recently, virtual appointments for routine clinic reviews. So how does the virtual ward work? Most of our patients being cared for on the virtual ward attend the CF Centre for their initial assessment and are given their first dose of IV antibiotics under clinical supervision. Some of our patients, however, do start their IV therapies as an inpatient and are stepped down to the virtual ward to facilitate early discharge and allow them to complete their treatments at home. Patients are given a handheld spirometer and they take their initial measurements with the spirometer on their virtual ward admission day. And we do this to ensure that we have comparable data for future use of the spirometer when they go home and use it on the virtual ward. We discuss the virtual ward support with the patient and admit them to the virtual ward on the electronic patient record system. And then the patients have their home IVs delivered from the hospital pharmacy in pre-prepared infusion devices. So on days 7 and 14 of their home IV antibiotic therapy, the patients are contacted by a member of the CF team who carry out a telephone consultation. So this telephone consultation follows a standardised proforma, which includes adverse effects, symptoms, nutrition, sputum clearance, activity levels, and general health status. And any issues that are highlighted are then directed to the appropriate professional to deal with. The CF consultant oversees all virtual ward activity, and patients on the virtual ward are discussed at our weekly MDT meetings. And we aim to discharge the patients from the virtual ward upon completion of their IVs, and a discharge letter is sent to the patient and their GP. So looking at the virtual ward activity so far, the first graph here shows the number of admissions to the virtual ward per year since 2023. So those patients in green are the ones who have had an early discharge facilitated from the hospital by being supported to finish their IV therapies at home, following an admission for an exacerbation. And then the blue colour indicates the proportion of patients who have been admitted to the virtual ward as an outpatient. So that's supporting admission avoidance. The second graph gives an indication of the division of virtual reviews according to profession. So we hold a brief weekly meeting via Microsoft Teams where we discuss the patients on the virtual ward and those that are being planned to be admitted to the virtual ward that week. And then during the meeting, we allocate who is going to take responsibility for those reviews that week. So we do that with staffing levels and other clinical commitments in mind. But it is worth noting that the service was started off involving one physiotherapist, one dietitian and one nurse. But we've now progressed that. We now have 2 physios on the team and 3 nurses, but we still only have 1 dietitian on the virtual ward team. So then the final chart displays the overall repeat admissions to the CF virtual ward over the years that it's been running. So it shows from the number of patients who have had more than 1 admission that the virtual ward is often a preferred and accepted clinical approach to IV therapies. So what do the patients think? 87.5% of our patients reported that the virtual ward service was helpful, scoring an average of 8 on a scale of 1 to 10. 83% preferred to have home IVs, 8% preferred hospital IVs, and the remainder were neutral. Only one of the respondents reported an issue, which was the odd occasional issue with delivery, and there were no other problems identified. But admittedly, this feedback was gathered verbally from the clinicians who were running the virtual ward. So it would be interesting to see what anonymised feedback on the service would be like. So since the virtual ward has been established and shown to be successful, we decided we were going to progress it a little bit. And we were going to start to offer a telehealth service to other areas beyond home IV support. So with the number of women with cystic fibrosis giving birth increasing significantly since the introduction of CFTR modulator therapies, with the UK CF registry has documented 111 births in 2024 to women with CF. So we thought that it was important then to start to increase the support, seeing as we were seeing more patients who were successfully giving birth. So in the past 2 years, we have had 18 women with CF from our centre who have given birth. And these women have particular needs in the postnatal period to maintain their own CF care whilst looking after a newborn. So as part of developing the services for these women, we have begun to offer virtual consultations with the multidisciplinary team. So this includes the CF consultant, a physiotherapist, dietitian, and the CF specialist nurse. And we use the Attend Anywhere video calling platform. And we do this around 4 to 6 weeks postpartum. So this review focuses on CFTR modulator related issues for mother and baby, maintaining maternal treatments, nutrition and breastfeeding, contraception, pelvic floor advice, and MSK advice. And we also try and get the patient to do their home spirometry as well for those reviews. So feedback from the postnatal virtual reviews has been positive. All patients found it helpful, and they gave it scores of 6 to 10 out of 10. All patients would prefer virtual rather than face-to-face reviews, with many commenting on the reduced travel alleviating childcare issues. And patients welcomed the support postpartum and the opportunity to have questions answered, as you can see from the feedback there. So because that's all been successful, we decided to progress it even further. And now we're looking into progressing our telehealth for normal standard clinic virtual reviews. So this service is still in its infancy, so I don't have any feedback on it yet, but all of the ones that have gone so far have been positive and we haven't had any issues reported. So for this service, the appropriate patients are identified by the CF consultant. So they will consider normally the more well patients initially, just to be on the safe side, and looking at those who have transport difficulties or childcare issues or work commitments that might stop them from getting to clinic. The virtual follow-up is discussed with the patient at their normal clinic appointment, and they're issued with a home spirometer for their next virtual review. And then for the planned virtual review, one member of the MDT is allocated to carry out the review and will refer to their specialities as appropriate. So over the years that we've been offering telehealth as a service, we've used 4 main digital platforms, with 3 of these remaining in use over our virtual healthcare offering. So I've included here the 4 platforms and sort of their main uses and their key strengths and limitations. But from a practical standpoint, I do think that there is work to be done on getting one integrated, combined digital platform that would include all of the key features that we need. So, for example, Microsoft Teams is widely accepted. It's widely accepted digital platform in the UK. It's well known by NHS staff, but it's not set up for clinical consultations, so it wouldn't allow for overrun appointments or anything if we were to do clinical appointments with the patients. We have Attend Anywhere that has a waiting room service, which is great. So patients can wait. If your appointment's delayed, you can message them. But there isn't an option just to call patients, and some patients don't want to be, or it's not appropriate to be on a video call. The Florence system is now outdated. It involved patients actually actively texting in their details, which was great when we were first starting off, but this has been superseded by more complex things like the chipped devices and things, which just work a lot better. And then Health Call. So we're on to Health Call now. It was created in collaboration with NHS trusts in the northeast of England, and they are trying to expand their role to extend their reach nationally. But from a practical standpoint, again, Health Call isn't equipped to integrate with the electronic patient record, so it can be really time consuming to transfer all that data from Health Call onto the patient record. And it's difficult on weekends and things if people get admitted and that information hasn't been transferred. And in our trust, Health Call is only accessible via a trust-issued device, so that drives the costs up. So we have to issue a tablet to patients who probably already have one at home, but it has to be an NHS-issued device to use that. So as well as offering seamless integration with the electronic patient record system, ideally an integrated platform would give clinicians a familiar digital environment which would boost user acceptance and would reduce onboarding time and effort. And it would also improve the patient experience if a more user-friendly and integrated system was used. So there are many known benefits to telehealth, including improved access to care. Remote consultations can be particularly useful for patients in rural or underserved areas. So it can reduce travel time and costs for patients, but it can also reduce costs from clinicians who would normally have to go out on a home visit. It offers convenience and flexibility. We can offer appointments outside the scheduled allocated clinic slots if necessary, and we don't need to consider microbiological considerations. We can ensure patients are managed safely and effectively in the right place at the right time. We can deliver hospital-level care at home using an MDT approach and technology. It enhances communication between the patients and the CF team. A major benefit is reducing the risk of cross-infection by limiting patient exposure to the hospital environment. We can lower overhead costs by reducing unnecessary hospital visits and facilitate admission avoidance or reduction in length of stay. And with the aim of introducing wearable devices, we will be able to access real-time data, which will support proactive and preventative care. And then we can also treat and monitor patients, or more patients, without expanding our physical infrastructure. So in our experience, telehealth is feasible and useful in providing additional support to our patients. It provides reassurance for the clinical team when we're treating patients with advanced CF at home. But it does, however, come with its challenges. One of the obvious challenges to telehealth is the digital aspect. So many people have limited access to devices or internet services, or can be put off by unfamiliar digital platforms. There's always a different app for something. And I think that really puts people off that there's not one single user-friendly device. And we can exacerbate health inequalities. Technical issues during or before the appointments can really disrupt the telehealth care and can deter patients from engaging. And I did mention when talking about the telehealth that it was a positive that appointments could be made outside of routine clinic slots, but it does come with the challenge of finding some space to do it. Often you have, if it's a virtual appointment, you're not allocated an in-person sort of clinic room. You can't do these appointments in offices. It's trying to find somewhere with the appropriate IT and the appropriate privacy to do these things. And then when providing telehealth services, we also need to ensure that we use a secure platform with robust cybersecurity measures in place so that we don't have any data breaches. But there are also aspects like the reduction in physical examination and microbiology surveillance to consider. With telehealth, hands-on assessments aren't possible, so we do need to have a low threshold for arranging face-to-face reviews if we come across anything concerning that would benefit from a physical examination. And a major challenge for us, and I believe a lot of other services in the UK nationally, is the challenge of getting sputum samples from patients who attend their clinic review remotely. We're still looking at postal services for these samples, but we need to make this as hassle-free as possible for the patients to make sure that they engage. So it's important to consider each patient on an individual basis to assess whether telehealth is appropriate in their circumstances. Part of the concept of the virtual ward is to be able to provide clinical and multidisciplinary support with the more caring elements of human interaction, for example, rest, food and heat, being provided in the patient's home or in their care setting. However, sometimes that human interaction is missing in the patient's homes. So that negates it kind of undermines the potential for virtual care. We also need to address the patient perception of telehealth. It's often referred to as virtual healthcare. So patients can perceive this as suboptimal, and they often think that they're less supported by the team. So some patients feel that it puts them at an increased risk and prefer to receive their care in the hospital because they feel it's a safer environment. So work is definitely required to improve the patient perception of telehealth and to collaboratively build a service that meets the patient needs. So whilst we have experienced success in our telehealth journey so far, it is important to continually strive to improve the provision of healthcare services beyond the hospital walls. Work is required to embed an integrated digital platform into a single user-friendly location, and we are beginning to consider the most appropriate use of wearable devices to help with remote monitoring without increasing the treatment burden for our patients. Finding a solution to the ongoing issue of delivering sputum samples to the hospital is a high priority to ensure continued microbiology surveillance for those accessing the telehealth service. So we are going to continue to work closely with the patients to design a telehealth service that is responsive to their needs to ensure accessibility, convenience and continuity of care while maintaining high standards of clinical safety and quality. So finally, I just wanted to acknowledge all of the multidisciplinary team at the Newcastle Adult CF Centre for their hard work and support in developing a telehealth system that is fit for the future of our patient care.
If you have questions, please step up to the mic and or use the app.
No. I have a question. I was on the question. No. Can I, how many people have you had on the virtual ward?
I did wonder if someone would ask this, and I actually haven't made, because we've done it for a few years now. We haven't kind of split up that data deliberately into specific patients. It's normally admissions to the virtual ward. So we have had several admissions over the years. We do have quite a few sort of repeat people. It's those people who are having regular IVs that tend to kind of keep going back on it. So unfortunately, I don't have the exact numbers. I probably should have prepared that for coming here. I apologise.
Does it affect your workload?
Yes. It hugely affects the workload. And I think that's the issue. A lot of the time, one of the benefits is that it's, people say it's cost improvement maybe, and looking at the cost effectiveness of it. But the difficulty that we have is that that's then additional to our normal daily caseload. So we, and I think from an outsider's point of view, people might say, oh, it's 5 minutes, it's 10 minutes or whatever, but the amount of then the meetings that we have for it, the chasing up of patients, the sharing of information with the relevant people, writing discharge letters. We don't write discharge letters for routine clinic appointments. So it does hugely add to the workload without being given any additional resources for that. But then equally, it's not always about the cost, and it's about adapting the service for the patients and to benefit the patients. And we do feel like the patients really appreciate that service. They appreciate being offered that. And I think it's important that we continue to look at cost-effective and sort of cost-effective ways of doing that would meet their needs. Thank you. Awesome. Thank you.
Thank you, Laura. All right, our next speaker is Lucy Gale, who is a senior research dietitian and clinical project manager at the Heart and Lung Research Institute at the Royal Papworth Hospital in Cambridge, UK. Lucy project manages. Sorry, you all.
Right. Sorry, it's not Gina, it's me. Project Breathe.
Oh, you want to finish?
No, you can do it. Project manage a range of home monitoring studies, including Project Breathe and the ACF study.
Thank you. Which includes Project Breathe ACE, using which she will tell you more about in her presentation. Sorry, Lisa.
Thank you for the introduction. Thank you for the organisers, and thank you for Lisa to inviting me to come and talk to you today. Regarding disclosures, we have had some funding previously from the CFF for our past studies, so we're very grateful for that. So I'm just going to talk to you about some of our home monitoring work that we've been doing. Apologies if anybody was in my previous session, it is a little bit different to this one. And just talk you really through practicalities, which is what Lisa asked me to do. So we all know that acute pulmonary exacerbations, or APEs, are a massive problem, and actually predicting when somebody's going to become unwell is a challenge. And actually it's become more of a challenge now with modulators, because symptoms of exacerbation look different to how they looked pre-modulators. And coupled with that, we've got sometimes inefficient or insufficient resources, and the tests that we do have are quite subjective, and they can be quite insensitive. And there's absolute patient-led demand for change. They don't want to come to clinic when they don't need to. Why would somebody want to take half of their day out to come and sit in clinic to be told that they're fine? And then also there's a risk of cross-infection. If we could use home monitoring to help us predict exacerbations, maybe we could treat people sooner and prevent long-term lung damage associated with repeated infection and repeated severe damage. Could we just do virtual clinics? And could we support those virtual clinics with home monitoring data? So instead of a snapshot, you get really rich physiological data to make clinical decisions. And also now we need to think about, can we withdraw treatment safely, and could we monitor that from home, as well as relief from overstretched clinics? And it's just to add that this home monitoring doesn't mean that you need a quarter of the amount of staff. It's actually, as our previous speaker alluded to, you do need to make sure you've got sufficient staff to run it effectively. So we've been running home monitoring studies for over 14 years now, and I just want to give you a little bit of an insight into what we've been doing, some of the things that we've found and where we're going next, with a focus on practicalities. So we started back in 2011 with telemed, which was just our pilot study in 15 patients, and that was just at Papworth. And then we moved on to our feasibility study, SmartCare CF, which was across several centres in the UK, and they were on that study for 6 months. And then we were able to move into our implementation studies because those previous studies were successful. So Project Breathe was the biggest one of those, which ran for 5 years and finished back in 2023. 24, goodness, time flies. And then that was 475 patients. And then we moved into ACF, which is currently running, and I'll talk to you more about. And we thank our funders for all of that. So just focusing on Project Breathe first. Some patients were in it for a 6-month minimum period of time, and some of them stayed in it up to 5 years. Sorry, I'm losing my voice. So with Project Breathe, we had centres taking part across the whole of the UK, so which was fantastic. And then we've recently had a study running in Ontario in Canada, which has been lovely to work with those guys, and that will finish early next year. So with all of these studies, our patients were given a range of home monitoring equipment, and this included an activity monitor, a handheld spirometer, and a oxygen SAPS probe, which also monitored heart rate, some weighing scales. And patients were also asked to do a subjective assessment each day of how well they felt, just on a Likert scale, and how much they were coughing. So this all fed through to an app that we've developed called Breathe RM. And we've developed that and refined it over the years with our patients, and added to it as patients have asked us for things. We can add in notes to it. We now surface more information. So patients can see their trends in their app, and also the clinical team can see the data on a clinician portal. And we took advice from the clinicians because we wanted to make sure that the data that was surfaced was easy for them to see, and I'll show you that in a bit more detail. So all of the equipment that we give out to patients links up via Bluetooth. So as this is a research study, our research team go and talk to our patients and link up each piece of kit. So you can see on the left-hand side, that's a screenshot of the Breathe RM app. And we work through each bit of kit, set it up, and then it links via Bluetooth. So that therefore means once it's set up, all patients have to, I say all, I don't mean all. Once patients have used the bit of kit, it just links up via Bluetooth, comes through to the app, and then comes through to the clinician portal. So there's no manual writing of any parameter measures. And then on the right-hand side, you can see an example of the clinician portal. Now, unfortunately, the clinician portal's developed over the years, and it used to have a lovely black background, which made everything easy to see, but it isn't so easy when I'm showing it in talks. So it's nice and easy. We go through each piece of kit with a person. Sometimes it needs no explanation. Lots of people are really good with tech now. Some people need a little bit longer. But the initial stage, the setting up, is absolutely vital. During COVID, we did do some setup over the phone or virtually. And for people who are tech savvy, that was great. But having just run a study in non-CF bronchiectasis where patients tend to be older, some of them were way better at tech than me or most of the team, but some of them really took a long time to get to grips with things. So it's ensuring that first bit is good. And if everyone's set up properly, then they tend to manage much better with the tech. If it doesn't work so well from the beginning, people tend to find they get a bit disillusioned and they lose some confidence in the technology. So we've tried to make it easy to see trends in data rather than just getting a snapshot in clinic. And we also like to think of the holistic overview, so how people are feeling that day, and then put all of this together. So, it's not too bad. I don't think it would be great from the back, sorry. This is an example of our clinician portal, which, as I said, we developed with the clinicians. So each box at the top is a different physiological parameter, and the numbers in bold or the letters in bold are today's value, the reading that's just been done. And then underneath there's a range, and you can set your parameters for the last week, the last month, the last year, however you want to do it, so you can see where today's reading fits within their normal range. And then you can also put these onto graphs so that you can see what the trends look like nice and easily. And we can overlay, so say if you wanted to look at lung function and weight, or what their heart rate's been doing, or calories, or any of those things, you can play around with the graphs and overlay them. We can also add on to here, so this patient hadn't had IVs during that period of time, but also there will be a column on the graph where you can see people have had IVs. And then they can also add in if they think they've had cold or flu or hay fever symptoms, because obviously that can affect their readings. If they've had hemoptysis, or if they'd like to add any notes about events that might have had an impact on them. They might have been on holiday, they might have been admitted to hospital with a broken leg or something else, just to put the figures in context. So, we found with our analysis on Project Breathe that patients felt a greater sense of empowerment to take control of their own health. And home monitoring isn't for everybody, but for those people who want to use it, we've found really good results. We had a positive impact on lung function over 6 months, and we had a reduction of almost 30% of days of intravenous antibiotics. And this lovely lady in this picture is Sammy, who's been instrumental in helping us with our patient input throughout all of these studies, and we're very grateful to her. And this lovely lady is Katie, who has done a quote. So she's found it very helpful. I will let you read it. Okay. So one of the big things that gets fed back to us is how anxious some patients feel coming to clinic, particularly when they haven't had any readings since the previous time they came to clinic. And it can be really, really difficult for them. And the biggest thing we've had feedback is, I'm coming and I know what I'm dealing with. I know what my readings are. I can prepare myself mentally. If I need to come in, I think my readings aren't looking great. I can prepare things at home. I can make changes. Or actually, this is going to be all right today. My readings are looking fine, or they're looking better. So that's had a really big impact for people. But as Katie said, the anxiety only goes down when things are stable and when things are going off. I don't know whether for some people it's better to be forewarned, or for other people it makes it more difficult. And then just having a look at smart care. So this is where we went to use all of our home monitoring data to develop an algorithm. So this is to help predict decline in health status. I'll talk you through this slide. So on the left-hand side, what we wanted to do is to look at what a typical respiratory exacerbation looked like. And all these different colours on the left hand relate to different physiological parameters. So for example, you've got oxygen sats in yellow, pulse rate in purple, lung function in red. But they all follow a very similar trend. So the black vertical line, jet lag, is where an exacerbation is starting, day 0. Now, there's a very flat line at the top, and then there's a decline in all of parameters. Now, what we found interestingly is that day 7 or 8, there was a slight uptick in all the physiological parameters, and we wonder whether that was due to people doing a little bit more of their treatments. And then there's a terminal decline in all of their parameters until antibiotics are started. Then we looked a little bit further at these 2 examples to see, well, could we track when somebody's going to become unwell before they know they're going to become unwell? And actually, yes, we can. So with all of our very clever machine learning and data analysts back at Cambridge, they use this algorithm and can detect up to 10 days earlier than symptoms appear when somebody is going to decline. And you can see if we could get those antibiotics in sooner, right back 10 days earlier, what an impact that could potentially have on preserving lung function as well as everything else, that quality of life for the patient. And then briefly just onto ACF. So because of the good results that we've had from our previous studies, we got funding to open a multi-centre RCT looking at home monitoring versus home monitoring plus the predictive algorithm. And I'm going to talk you through what we do in this study. So patients are randomised 1-to-1, so there's the same amount in each group, and if they're randomised to see this predictive algorithm, it's like a traffic light. So they need to put in about 25 days worth of home monitoring data for the system to establish their baseline. And then once the system's established their baseline, when they put data in day to day, it will surface a colour. So green means you're doing great, carry on. Amber means it looks like there's probably a bit of a decline in your parameters. You might want to up your game a little bit. If there's anything you can do to do your treatments better, or you might want to consider calling your team if you're not feeling well. Red means we've detected a decline. We think you've got an exacerbation coming. Please contact your team for an assessment. And then if they're receiving treatment for an exacerbation, we put them on pause. Otherwise, it would affect their baseline readings, and then they'd look like everything wouldn't work in the system. So hopefully that makes sense. There's also a white category, which means there isn't enough data coming through to us to safely predict what's going on with you. So in the background of all this, we have a safety classifier, and there has to be enough good quality data for them to get a colour, to make sure that we're not acting on something that we shouldn't be. Now, obviously, this is a learning curve for clinicians and staff and patients, because, well, it's a little bit strange to be told you're unwell and you feel absolutely fine. So we're looking forward to seeing what results we get from this. So the follow-up finishes early next year. And this is just some comments I thought you might like to see about home monitoring from various studies. So one patient recently said it just takes the same amount of time as to brew a cup of tea. So in England, we've got a saying of builder's tea where it's really strong. So I suspect they leave their tea bag in for a few minutes. But anyway, it's quick. We've already talked about reduction of anxiety in clinic. Some patients use their kit more when they're unwell. Some people use it less when they're unwell. Some people like to measure all the time, loads and loads and loads. They love seeing the graphs. They're really into it. Some people dip in and out. It's different things work well for different people. And they really like doing virtual clinics. We've done virtual clinics for a long, long time. And we don't just do virtual clinics, but there's the option there for people to choose whether they want to or not. And it's nice to see that quite a lot of patients have continued to use the technology even after they finished on the research part of the study. So the Breathe RM app's freely available for people to download, but we don't continue to fund the equipment, which is a practicality that we're now working through because it's no longer a research project for Project Breathe. So for future, we would like to think that instead of conventional care where patients feel unwell, they ring their clinical care team, they wait for an appointment, and then potentially they might wait for a bed or another clinic review, and then start IV antibiotics. It might be at home, it might be in the hospital, compared to what could happen with home monitoring, where people are monitoring their health at home. They've got good insight into what's going on with them. They can see a dip. They can contact their team, or we also give our patients reserve antibiotics to take if they feel they need to, and then continuing on with virtual care. We would love to see people needing less treatment and less long-term lung damage. So that's my insights. I've got a lot of people to thank, but the biggest group of people to thank is, of course, our wonderful patients. And thank you very much. If anybody's got any questions.
That's great, Lucy. We'll take questions. Thank you very much.
Hi, thank you for the thank you for the good presentation. My question is, I saw comments of feeling like reducing anxiety. Have you seen the opposite with any of your patients? Because I know sometimes that monitoring, especially in the acute setting, they get fixated on that monitor.
Absolutely.
And have you seen that opposite effect at all?
Yeah, it's a good question. So we thought there might be quite a lot getting very anxious, but I think they'll self-select for the studies. It's interesting to see when we rolled it out to, we rolled out all of the technology during COVID so that anybody could have access if they wanted to. I think they just don't do the data. So we've got some patients who don't want to know about their weight, so they leave that bit of kit. But we certainly have had a few who've got very fixated, but I've lost track of how many patients we've got, 400 and something, really a handful. And then we help them find other ways to monitor themselves if they want to. Absolutely.
Hi, thank you so much for your presentation. So I'm a parent. My daughter has cystic fibrosis. She's 3. So it's very much up to me and my husband to manage her health. So kind of to follow up on what you were saying, are they able to see, I know you were showing from the clinician side where you're able to track it and you can see the data, but not just in what it looks like today. So are the patients able to do that from their side as well and do the overlays, play with graphs?
Yeah, they can do the same thing within the app.
Okay.
So they can move it around with times, but obviously it's a much smaller screen.
Sure.
So yeah, but they can see it.
Gotcha. Okay.
Thank you.
And Lucy, you said that the app's available to anybody that wanted to download it. So they just needed to have a compatible device and they could use that themselves, even in a different country.
Yes.
Oh,
okay.
Okay. Yeah.
Yeah.
It's just Bluetooth.
As long as your equipment links up via Bluetooth, and even if you didn't have the kit that linked up by Bluetooth, you can manually enter. We obviously just wanted to make it as slick as possible for people to use.
Because sometimes if you're in hospital, the Bluetooth doesn't work. Sometimes there's brick walls that are too thick or whatever, but you can actually manually use it. It's quite useful as a clinician to have it on my phone, so if we're ever going through it with a patient, you can show them how to start it up and do that as well. And I'm not part of the research team, our patients did get enrolled in some of it, so it's quite useful. One question I had is how many patients, how frequently are they uploading data? I know that for the ACE they were supposed to do it daily. How actually often do they upload the data?
So at the beginning of this big RCT, obviously we have to meet all of our research, our funders' requirements, and make sure we get some outcome data from it. So when we started off, we asked people to upload daily data. And as we've gone along, we've been looking at the relative contribution of each measure to detecting exacerbations, and we found actually they don't need to do it every day. So we're encouraging 3 or 4 times a week, which is still not insignificant, but is giving us good data. We're also looking at, controversially, I don't know if I should say this in this room, that lung function doesn't provide quite as much information as maybe we thought, and that other parameters are providing more information than we thought. So we've got a real mixed bag. Some people, obviously it's shiny and new at the beginning. Everyone's doing loads. Great. Then there's a tail off over time. Some people, as I say, dip in and out. Some people have been on these studies for the whole almost 15 years. So they're obviously massively dedicated and they do loads. Other people give it a try at the beginning and think, oh, it's not for me. We
find that with airway clearance devices as well. That's great.
Okay, thank you.
Thank you very much, Lucy. Yeah, your turn. So it's my pleasure to introduce my co-chair, Gina. And just before at the end of this, we do have more question time and we do have a panel discussion. So I'd encourage you to stay because we do have more questions and you can ask anything of any of the panel members. So please do stay. So Gina has been an RT for 30 years and she has a master's in public health. She's the lead CFRT at Innova Fairfax Hospital and she's in charge of the only CF specific exercise programme. She works in CF, bronchiectasis and transplant patients and in the pulmonary rehab programme where she exercises, educates and advocates for her patients. So I'd like to welcome Gina.
Thank you. I want to say thank you to you. Thank you for pushing me to do this. Hello, everyone. Thanks for showing today. I'm going to be talking about wellness with online pulmonary rehab patients for our CF patients. We don't currently have in our hospital online or virtual wellness per se. We do have telehealth for our physicians when they have our patients come in or when they can't make it for visits or whatever. But as far as for pulmonary rehab or any type of exercise, we don't have a program just yet. There's many reasons why, but I'll talk about them as I go along. I don't have any disclosures. As an overview, I know we all know that cystic fibrosis is a complex, multi-system disease that affects your lungs, it affects your digestive tract. It's thick secretions, thick mucus everywhere. It sits in your lungs, and you get sick. You get more pathogens and more infections, and then you're hospitalized. Traditionally, chest physiotherapy and inhaled medications, our regular clinic visits help to manage our patients, but chest physiotherapy and inhaled medications are foundational, but they're physically taxing to our patients, and they're challenging logistically. If you don't have somebody at home with you to help you with CPT, it's going to be difficult for you. You're not going to have that. Everyone does not like chest physiotherapy in terms of the vest. Sometimes they fit right, sometimes they don't. So we have those challenges. Digital health innovations offer a transformative opportunity that allows us to deliver personalized access therapy remotely, which reduces barriers and enhancing continuity of care. The common challenges of CF rehabilitation are, of course, your limited access, cross-infection, low adherence, because our CF patients don't always adhere to what we're asking them to do. But despite the advances of CF rehabilitation, faces persistent challenges, limit access to specialized care, and geographic isolation can delay treatment. Adherence is often low due to fatigue, mental health issues, a lack of motivation, and technology can help us reframe the therapy and engaging in achievable outcomes. Digital access and literacy are not just technical issues, they're equity issues. We must design platforms that are intuitive and inclusive for our CF patients. Data privacy is a non-negotiable. Patients need to trust that their health information is secure and that they understand their health information. Innovation like AI-driven customization, virtual rehab-based rehab, and predictive analytics are reshaping how we deliver our care. These tools allow us to tailor therapy to individual needs in real time. Collaboration is key. When clinicians and developers and patients create solutions, we build platforms that are clinically sound and user-friendly to help overcome challenges for our patients. Virtual coaching. There are 7 key outcomes to virtual coaching. They are lung function, exercise capacity, dyspnea reduction, quality of life, adherence, hospitalization reduction, and mental health. Virtual coaching has demonstrated measurable improvements across 7 domains. These outcomes reflect not just clinical gains, but also the holistic impact to remote support and have patients feel empowered, more connected, and more in control of their health. Here's a 5-year comparison of virtual coaching outcomes. This chart shows improvements from 2001 to 2005. For example, adherence rates rose steadily and hospital rates declined. These findings are backed on Murillo and Keeley in 2025 and DeMachis of 2025 who highlighted a scalable and effective virtual coaching across diverse CF populations. I pulled a couple of just examples of what was said in some of the studies that were done with adults and pediatrics for their success stories. And after being coached and having virtual visits, they've improved in adherence for 14-year-olds, which is pretty big because 14-year-olds don't do what you ask them to do anyway. So for that to happen, that was profound. You have your adults who improve on their VO2 max through home-based training. You're doing strength training and you're doing muscle training for these patients, and that improves their lung volumes and their lung capacities and their FEV1s, which when they get on treadmills or when we do our studies they improve with their VO2. Pediatric CF patients showed improved muscle function via telerehab. I don't work with pediatric patients, so I don't know that trouble, but I'm sure that was difficult. And for them to have improved muscle function is a good thing. There's some therapy outcomes in person versus virtual. The study was done with 622 CF patients across 18 different studies, found that a profound increase in FEV1 and exacerbation reduction pretty much are the same between the two, virtual or in person. But I think that's pretty profound because we always thought that if you have to be on the other side of a TV or whatever, you can't learn, you can't get the same effects of being into a group of people. But this shows here that whether you're virtual or whether you're in a class, that you can still get the same improvements and you can still go down with your exacerbations. I just put this here because I thought it was pretty significant when you think about telehealth benefits with CF patients. The percent of improvement is profound. You have access to care when you're doing telehealth at 90%. That's pretty good. It is hard to get to people to come in. They have problems with transportation, funds. It's hard to get. Some of them are geographically too far away and it's hard for them to get in. But if we can get them in a telehealth program, or if we can do a telehealth, they improve their access to care. The same with the adherence, the multidisciplinary support. Every team member in your center can talk to and get a grasp on what's going on with the patient so the patient can get better care. There's early detection. It went up to 75%. And patient satisfaction, 95%, which is another difficult thing to do. That trust builds when you're with your patient, whether online or in person, you're building that trust, and that also helps with your satisfaction and the adherence to care. And then it's cost effective because you're not coming into the center, you're not using, I guess a bad way to say it, but you're not taking up space. So the center doesn't have to worry about the cost of that, but you still have your care. Patient feedback and future trends. Patients are consistently report high satisfaction, citing flexibility and reduced infection risk. Looking ahead, we anticipate deeper integration of AI personalization and wearable tech. There is also a growing need for CF-specific platforms that reflect the unique needs of the population and their caregivers. Digital health integration in CF care. The use of smart devices and AI-enhanced diagnostics are already improving remote monitoring and personalized care. Integration with CF registries and health records, electronic health records, will allow the seamless data sharing and clinical decision making. However, we must address challenges like data security, interoperability, and reimbursement to ensure sustainable adaptation to for adherence for our patients. The benefits of telehealth for patients, as my colleagues before me spoke, they're pretty much all the same. They're pretty much in no matter where you are. But one thing that sticks out between the UK and here in America is reimbursements, and how things are paid for. So the benefits to that are pretty much, like I said, the same, but the only downfall is the reimbursements and the pay. That's the only downfall in my opinion. I think that telehealth is a great thing for all patients, but our CF patients especially, because they need that support. Components and accessibility of virtual pulmonary rehab. Core components include structural exercise, education, self-management tools. Accessibility is a major strength. Patients can participate from anywhere with internet access. That is the best thing ever. Motivation and support. We can do that through goal tracking, peer groups, progress dashboards, small group online talks. The adaptation to that, the challenge to that is that the reimbursement rates from Medicaid, Medicare are low, and most hospitals here won't pick that cost up because it's not beneficial. Here are some of the reimbursement codes. Here they're billed every 15 minutes. There only are certain codes that you can use for the reimbursement on digital health is it's a G0238 code, which is in between those two. You can't see it, but it also depends upon where the patient lives, what their condition is, how severe their condition is, and which type of Medicare, Medicaid they have before it would be a reimbursement or paid for or even considered. As you can see on this chart here, the 94626 is a common code for 2024. Going into 2025, I believe that code is going to change. And right now, if you look on the left side of that, that's the rate of return or reimbursement, and it's like just under $20. I think when I looked at the scale, it was going up maybe to $23 reimbursement per session. And most programs won't pick that up because it's just not viable enough for the service. So we need to figure out how to make those changes and get those things done so that our patients can have access to care. Enhancing engagement through interactive platforms. I thought this was pretty interesting. Gamification and motivation. So if you have apps I like the app where you can see the stoplights and things like that. I think that's very good, very interactive. We need more of those because patients, when they can get involved, they'll be involved in their care more. Community support features, social sharing, peer connections, fostering a sense of belonging. That's that trust that we try to get with our patients that we need to work more on. And virtual is not bad to do that with. It gives you another step to work with your patients. Future technology and integration, of course, the AI driven, everybody is going towards AI. And if it works, I say, let's use it. Some of the AI stuff would be, let me see if I can find it. Smart inhalers. that track adherence and optimize medication through delivery. Integration into healthcare requires intuitive design and robust security to protect your patient data, your AI with your wearables, those things of that nature. My closing and summary for future directives, key takeaways: online pulmonary therapy is effective and comparable to in-person care. Telehealth improves access, adherence, and patient satisfaction. Virtual coaching improves multiple outcomes. And CMS reimbursement supports broader adoption into telehealth versus virtual. There, I didn't know that there was a difference, but telehealth and virtual are different here. Telehealth would be more so if you have a physician or your whole team. Virtual would be like a one-on-one session, and that does make a difference in how we're reimbursed and how it's allowed. Currently, there's no support for virtual pulmonary rehabilitation from CMS, and we have to get out there and talk to our legislatures and get those things changed so that we can care for our patients better. Future adoption would be to encourage integration of virtual tools in CF care. Of course, everything with the AI and the wearable integration, and then support ongoing research into long-term outcomes and innovation. That's all I have today. That was Chris.
Does anybody have any questions for Gina? If not, I can kick it off. My first question is, the patients are demanding a change. How are you going to get the reimbursement? Because if you can't deliver what they want, you're going to fall at the first hurdle. I know that's probably not something you can answer.
I can try.
Okay, rock on.
I feel like here, if you are more apt to going to legislature, you know, when we put out those calls for everybody to sign bills or to go and support on the Hill, I feel like we should. They're our patients, they're our responsibility, they're what we care for. So I feel that if we do more of that, it may make a change. I mean, that's hard to fight, but you have to fight in order to win. So I say you fight.
Great. Question?
Hey, Gina, thanks for your presentation.
Thank you.
I did pulmonary rehab for about 8 years, and it was like an 8-week program. We met twice a week, had a 2-hour session. One was education, one was exercise. And I'm just curious how your virtual pulmonary rehab is like structurally set up, as how you fit that all in the time.
Well, right now we don't do virtual because of, we were doing it mostly when COVID first hit. But since COVID, we have not had that opportunity to go back. But I say that the structure was an hour and 15 minutes. And, you know, while people are exercising, you talk. You can talk to them while they're exercising. You can make your exercise educational. You know, if they don't know about their lungs, you can talk to them about their lungs. If you want to educate about pursed lip breathing, let's have a session about pursed lip breathing. Right now, what we do is we have an airway clearance class. And in that class, we address all of that. As far as in our class, we took out the formal education part. And so the last 15 minutes while they're in session, we'll talk to them and pass out paperwork. And if they it's a 1-page education sheet. If they want to talk about it later, they can take it home, read it, and come back. But that's basically all we have right at this point.
So how long what were your virtual sessions?
Our virtual sessions, they were 8 weeks, 6 to 8 weeks.
But at a time you did like an hour?
Mm-hmm.
About an hour. Okay.
Yeah.
Thank you.
Mm-hmm.
Out of interest, how did you manage risk during the virtual sessions in terms of what would you give guidance about managing diabetes? Would you give guidance about what would you do if somebody had a fall online?
Yeah, well, that happened. That's hard. That's difficult. They did, when that happened, I think that kind of raised a lot of eyebrows because prior to that, it wasn't addressed. And once that did happen, they just talked to people about not pushing yourself so hard, not pushing yourself so far. If you're not capable of doing it, let's sit in a chair. If you're not capable of standing and doing what I'm asking, you need to be forthcoming and say, it's a no judgment zone. I'm not going to judge you because you're not able to do it. As far as other safety risks, everybody at home has pulse ox, so it was mostly heart rate and oxygen saturation that was being looked at. If they had patients that were heart patients, they did cardiopulmonary, they did theirs in our heart rehab. So we didn't, if they had heart issues, they would have to go into rehab for that. So.
Because some of the guidance would suggest that you maybe have a buddy system so that you know that you can phone somebody else. I know when we used Beam in the UK and you guys had Beam in America also, that you had to sign up for a class, you need to provide emergency contact details. So things like that are quite useful to think about if you're going to implement an online class, if you're in a position to be able to do that financially. But to know if it's your patient that you've got an access point, that if they do have an issue, that you can get back to them, or they've got a buddy with them that they could get help if required. It hasn't happened to us, but it is something that we're very aware of, and making sure that there's a cover for you if that occurred.
I'm so glad that you brought up reimbursement, because I'm a physical therapist and Medicare will no longer reimburse any telehealth virtual visits for physical therapy. And so I don't know if you felt this way when you do virtual, you kind of relax just a little bit with the timing, because when people are in person, you're trying to maximize their time.
Right.
And so you're in and out so quickly and you're just kind of going through them. But with virtual, I felt like we could sit down and slow down and give them the education that they need. Yeah. And I you're nodding. So yes,
I totally agree with that.
Yeah. And so it's a huge disservice for our patients now, because it is such a rush in person and you're having to go through. So you get that reimbursement and so you can bill. So yeah, it's hard to justify our services. Yeah.
It is. And our CF team, a few years ago, not a few, more than a few, about 7 years ago, after COVID or during COVID, when they were having issues with trying to get patients in, they created a CF exercise program specifically for our patients. It's a one-on-one program where they come in and you give one-on-one education, one-on-one exercise. And it's kind of like a first look at your patient when they first come in. I'm the first person that sees them. And if I see anything that's going on, when I'm assessing, listening to lung, listening to the breath sounds and things of that nature, hey, so-and-so's not doing so well. And then, I can send them to clinic, or they can call and get their antibiotics or whatever it is that they need. So that was a fix for the CF population. I really can't say that that's a fix for all. And physical therapy, we had a physical therapist, but yeah, same issue happened for us in that respect as well. Thank you.
I'd encourage everybody to stay because we're going to have a panel discussion now for the last 10 minutes. So I invite the panel up to sit and we'll take some questions. Thank you.
No more.
You
did it. It was okay though.
And again, unashamedly, please, if you have an opinion on digital health and want to have your say, please do follow the QR code, fill out the survey. I'm very, very interested in what you have to think and say about the use of digital health and the management of CF from a physiotherapy standpoint. So please do have a go. You have to be a physiotherapist or a respiratory therapist to fill this form in. Unfortunately, no medics allowed. Does anybody have any questions? I have a couple to start off with if nobody else has. I always have a question. Gemma, thank you.
I guess my question is about quality. So how do we make sure that, when we're doing things at home, that we're actually getting the best that we can in terms of, the best airway clearance, the best spirometry that we might have? What sort of things have you got in place or ideas have you got for that?
Shout, guys. Okay. Shout loud.
I can't shout today. So when we set up our patients with home spiro, they need to have an assessment and a session with our respiratory physiologists first. and to make sure that their technique is good. But I'm now panicking after listening to you. And we also send them home with a link to a video that's been done by our physios and respiratory physiologists, which talks them through practically how to do the technique. And when I can only tell you at the moment as part of the research study, but if we see a change in their parameters, we always check their technique, because it's amazing how often they just don't use their nose clip, or they're standing or just on one leg, or whatever they're doing one day. So we always check those, but that's the process we've got in place for that.
Again, when we have that, we just have them come into an airway clearance class, and they're taught proper technique. They give me a show bag so that I know that they are understanding it. They get my number and a card, email address. They can contact me to ask questions if they're not doing it right. And again, if their numbers are starting to drop, then we address it the same way.
I think probably just to add to that is that we would try and get them to do the spirometry on a video call. And it's not ideal because you're not actually there in person, but it just gives you that little bit of an oversight into how they're doing it and the technique when they're doing that. And also from our point of view, we haven't gone that far in between sort of virtual and in-person appointments yet. I think it will come when we get more confident with the results and things. But at the minute, we do know that we're going to see them for the next clinic appointment. So we've just got that little bit of reassurance that we're not leaving them for a long time if they are going to be doing the spirometry poorly, I suppose.
Gemma, do you mean when you're doing telehealth, how do you keep quality up? Yeah, it's. I think that's really hard, and even if you're watching them on a video call, you don't necessarily know what kind of the profile patterns are if they're sustaining for long. And quality is a really hard thing, and people did ask even about Project Physio. In those people who were managing to remain in the blue box, for example, and showed real benefits in terms of lung health, they said, well, maybe, is that a proxy for something else that's going on? That people who've paid attention to those techniques or how they should be done are also people who perhaps exercise more and take their other medications. And so they're people who, in general, look after themselves far more carefully than those who perhaps don't. But I suspect if you're going to have people out there doing their thing, then having real quality control mechanisms, so making sure that techniques are recorded and you can see what they're doing to make sure that it is, it's taking, nebulizers or other inhaler therapies, that those are recorded when they're taken. But the temptation is to allow people to get on with self-care at home. And I guess there's a risk there that some people will fall between the net if they don't keep up qualities. It's a tech future, so hopefully those quality control mechanisms will ultimately be built in so we can help, I think.
Eleanor, when you've been, after the Project Physio, have you then gone back to the young people and children and said, this is what we need to do to change your technique? And on the adherence perspective, do you think that carries on into adulthood when they transition?
Yes, we didn't for Project Physio, and I think that we'll have an opportunity to do that a bit more in the Impact for CF, and actually built into the Impact for CF is that once they're on full coaching mode, everybody gets full coaching mode. Some will maintain on that full coaching mode and some will have it removed and go back to kind of baseline. And the idea there is to see, well, once you've been shown this is the technique, do you need to keep having the coaching, or can you, no, oh, well, that's what I'm supposed to do. And you maintain those good techniques without further input. And I don't know what the answer to that will be, but I suspect that our findings from physio was once the coaching had been removed, people tended to revert to their to their habits, and that was when we had gaming, gamification in that, and that gaming did help, but they'd slip straight back to what they knew. So I think possibly ongoing coaching might be required.
Yeah, so it's up to us to talk about quality over quantity quite significantly in clinic. I might have another question. Laura, when transitioning from peds to adults, do you do all their appointments virtually, or do you have a face-to-face as a preference?
We don't do any virtual transition appointments at the minute. So we, from a transition point of view, we spend the time in the paediatric clinic up until the time that they're ready to just be moved straight over to adults. So we do the joint appointments there. And we wouldn't tend to choose these people for virtual clinics right now. I think at the minute, just to err on the side of caution, the consultants are picking patients who we know are stable, and so if we know will adhere to doing the home measurements and answering the call when you have their appointment. And we don't tend to have that relationship quite yet with the paediatric patients, so we haven't had anyone really who hasn't been established in the adult service that has had home clinic reviews. We do, however, from a virtual ward support point of view, it is something that is taken up a lot by some of the younger people. They don't like to come into the CF unit. Some of them report that they feel it's like a prison. It's not fancy. It's not all colourful like the paediatric ward. And I think they really struggle with that. So we do try and encourage those people, if they're okay with doing home IVs, we try and encourage those people to be on our virtual ward so that they can still have their social life and still go to school and everything else, but be supported by us that little bit more.
Thank you. In the interest of time, and you get into your next session or lunch, we'll stop there unless anybody has any questions. And I'd just like to say thank you very much for your attention. And as I said, you won the prize. This was a good session. So please can we have a round of applause for our speakers?